Thank you for taking the time to watch our encore presentation of Preventive Services Prostate Cancer Screening. I would like to provide some clarification in regards to the U.S. Preventive Services Task Force recommendation. I mentioned that the task force has rated prostate cancer screening as a D. I want to clarify that this is for men 70 years of age and older. For men aged 55 to 69, the service is rated as a C, which means there is at least a small net benefit to receiving the service.
Thank you for joining us this morning to discuss Medicare coverage of prostate cancer screening. My name is Karen Curtis, and I am a provider outreach and education specialist here at WPS. Today, I am joined by my good friend and coworker, Aline Sigler. Aline will be monitoring the chat for questions, as well as providing you with some additional information and links. Here at WPS, we do our best to provide you with accurate, up-to-date education. If you've worked in Medicare for a while, you know that Medicare rules and regulations can change. So for this reason, the CMS website should be checked for updates, and the federal regulations take priority over anything presented today. Now, any questions that we answer will be based on the facts that are given. So if any changes to the information are made, that could change the response given. We also are not able to guarantee payment for services. Medicare rules will always determine final coverage of services. And if you have a claim-specific question, we do ask that you contact customer service. The provider outreach and education team doesn't have access to the system, so customer service has the ability to access your claim, and then they can provide you with an answer based on how your claim processed. Lastly, I need to let you know that CMS does prohibit the recording of this webinar. As I stated earlier, we are recording the event so that it can be posted to our webpage and YouTube channel as an encore presentation. Now, today we're going to cover some general information about prostate cancer. I'll discuss Medicare coverage and billing, and lastly, I'll discuss eligibility so that we can make sure your claims don't get denied for frequency. Now, the world of Medicare contains a lot of acronyms. So I've created a list of those that you will see or hear during my presentation. Many of you may be aware of most of, if not all of these, but I like to include them in case we have someone who's new to Medicare, or maybe someone who works in a field or practice where they haven't needed to know all of these. Now, if I mention any acronyms that you're not familiar with, you'll have these slides for reference, so hopefully that'll help. This is a copyright notice from the American Hospital Association National Uniform Billing Committee. This notice is required since I discussed coding that would be included on the UBO 4 or 837I. The American Hospital Association is not responsible for, nor were they involved in the preparation of this material or the information provided today. Let's get started with a little general information. The U.S. Preventive Services Task Force, also known as the USPSTF or Task Force, is a volunteer group that was created in 1984. The 16 members consist of national experts who come from a variety of fields, including family medicine, behavioral health, and nursing, among others. These individuals make evidence-based recommendations regarding preventive services. They focus exclusively on services offered in a primary care setting or services that are referable by a primary care clinician and apply to patients who have no obvious signs or symptoms of a specific disease. Each service is reviewed to determine if there is evidence that the service is effective and the balance of benefit versus harm. The service is then assigned a letter grade of A, B, C, D, or I. And services that receive a letter grade of A or B are covered without cost sharing. Now, the reason I'm talking about the task force today is because when it comes to coverage of preventative services, Medicare follows many of their recommendations. And as we go through these next couple of slides, you're going to see that screening recommendations really vary depending on the agency that they come from. Now, we'll start off with the recommendations from the task force. These recommendations are currently in the process of being updated, so what I'm presenting today may change. Now, at this time, public comments are closed, but you will find a link to the draft update on the resource slide in case this is something that you are interested in following. Current recommendations are that men aged 55 to 69 should make a personal decision if they want to undergo a prostate-specific antigen or PSA test for prostate cancer. Patients should have a conversation with their physician to discuss the potential benefits and harms before deciding. Men can experience a false positive test, which could lead to additional testing or even a biopsy. And as far as letter grades, the prostate screening is rated a D for men aged 55 to 69. So this means that the service has been determined to have a small net benefit to patients. For men 70 years of age and older, the service is not recommended. They just feel that the benefit does not outweigh the harm. The American Cancer Society also encourages men to have conversations regarding the benefits and risks before deciding to be screened. This discussion should take place between a patient and their physician at the age of 50 for men who are at average risk for prostate cancer and are expected to live at least 10 more years. At age 45 for men who are considered to be at high risk. And this is going to include African American men and those who have a first-degree relative, such as a father or a brother, who was diagnosed with prostate cancer when they were under the age of 65. Discussions should start at age 40 for men who have more than one first-degree relative who has had prostate cancer at an early age. Now, because prostate cancer is often slow-growing, the American Cancer Society does not recommend screening for men who do not have symptoms and have a life expectancy of less than 10 years, as they are not likely to benefit from the results. Lastly, the American Urological Association recommends that discussions occur between the ages of 45 to 69 for men who do not have any symptoms, and age 40 to 45 for those who are at higher risk. Although these organizations have recommendations that vary slightly from one another, one thing that is consistent is that the decision to be tested is an individual one, and it should only be made after talking with a physician to weigh the benefits and the risks. The Center for Disease Control estimates that about 13 out of every 100 men will get prostate cancer during their lifetime, and 2 to 3 will die from prostate cancer. So what are the risk factors? Age is the most common risk factor. As men age, the chance of getting prostate cancer increases. Studies have also found that African American men are more likely to get prostate cancer. They seem to develop this at a younger age, and the cancer seems to be more advanced by the time it is found. Finally, genetics play a role in a patient's risk for developing prostate cancer. The American Cancer Society has said that although most prostate cancers occur without a family history, there is enough evidence to show that in some cases it may be inherited. It has been found that men who have a father or a brother with prostate cancer have double the risk of developing the disease. There's also a higher risk if several relatives have been diagnosed, especially if they were younger. Now that you've heard the recommendations, we'll move on to actual Medicare coverage. Prostate cancer screening is covered under Medicare Part B. There are 2 tests that can be performed. One is the digital rectal examination, and the other is the prostate-specific antigen blood test known as the PSA test. These tests are available to men starting at least 1 day after their 50th birthday and can be performed once every 12 months. So in Medicare terms, this means that 11 full months must have passed since the last time the service was received. So to make it easy, we'll say if the patient received the test in January of 2024, then they would be eligible for the next test in January of 2025. Digital rectal examinations consist of a clinical examination of an individual's prostate for nodules or other abnormalities. The examination must be performed by a doctor of medicine or osteopathy, physician assistant, nurse practitioner, clinical nurse specialist, or a certified nurse midwife. This medical professional should be authorized by the state to perform the examination. They should have knowledge of the beneficiary, and they would be responsible for explaining the results of the examination. Coinsurance and deductible do apply to this specific test. The screening prostate-specific antigen is a blood test that measures a patient's level of prostate-specific antigen. This test must be ordered by the beneficiary's physician or physician assistant, a nurse practitioner, a clinical nurse specialist, or a certified nurse midwife. The medical professional should have knowledge about the beneficiary and would be responsible for explaining the results of the test. For the PSA test, coinsurance and deductible do not apply. So what do you need to put on those claims when you submit them to Medicare? If you are submitting an institutional claim on a UBO4 or an 837I, you're going to want to use the appropriate type of bill for the provider, right? So I've listed a bunch of provider or the type of bills that are applicable, and I've given an explanation of what type of provider would use those. I do want to mention an error in the CMS Internet Only manual. If you use the claims processing manual for guidance, the section on preventative services, that chapter where it talks about prostate cancer, it still lists a type of bill 73X as an appropriate bill type. The 73X was replaced with the 77X in 2010. So I just wanted to make sure that you were aware of that in case you do use that section for guidance, and I just didn't want it to cause any confusion. Both Part A and Part B providers will want to use codes G0102 or G0103, depending on which service is performed. Claims should also contain diagnosis code Z12.5. Now, again, if you're looking at the Internet-only manual, you'll find mention of another code. There are billing instructions for HCPCS 0359U, which is for an ISO PSA test. Now, this information was added in error, and it was to be removed with the implementation of CR 13396, but when I was looking at it the other day, it is still in there. So if you do use the internet-only manual, please disregard the information listed for this code. Now, if your claim contains code G0102 and you are billing on a CMS 1500 or 837P, you will want to use type of service 1. If you are billing on a UBO4 or 837I, you are going to want to use revenue code 770. If you're billing an MCS claim that contains code G0103, you will want to include type of service 5. And FIS claims will want to use a revenue code in the 300 series. Now, digital rectal exams are bundled into the payment for a covered evaluation and management service when they are performed on the same day to the same beneficiary. Now, if the digital rectal exam is the only service furnished, or if it's provided as part of an otherwise non-covered service, then there would be separate reimbursement if all other coverage requirements are met. If you are a rural health clinic or a federally qualified health center, payment for these tests are included in the all-inclusive rate, but CMS does ask that you include charges when submitting the claim for future inclusion in encounter rate calculations. Now, lastly today, I'd like to talk about eligibility. Checking eligibility before providing any of the preventative services can help avoid frequency rejections. There are a few options. We have the Interactive Voice Response System, or IVR. This is an automated system, and it will require you to enter a valid NPI, PTAN, and tax identification number. My co-host, Aline, did a whole IVR series, and that can be found on the CMS website as an encore presentation and also on our YouTube channel. For those of you who are registered for the secure section of our website known as the portal, there is a Preventive Services tab, which will show HCPCS or CPT codes and next eligibility dates. Now, this section of our website has been undergoing a redesign, and that should be released soon. So we'll be providing more information on that in the near future. If you're a provider who uses the Fiscal Intermediary Standard System, or FIS, and you have registered for DDE access, you will have the ability to view a beneficiary's common working file eligibility screens. Now, these screens provide next eligibility dates for a variety of different preventive services. Lastly is the HETS, or HIPAA Eligibility Transaction System. This is an option involving the electronic data interchange of files. So a 270 file is sent to request eligibility information, and then providers will receive a 271 response file showing the next eligibility dates. This does require your facility or office to be enrolled for electronic transactions through our EDI department. Now, I have provided you with some resources that I hope you'll find valuable. This top link is for the draft document that I mentioned earlier. If we go out there real quick. Here it has that the public documents are closed for this topic. It does give the draft research plan, So if that's something that you want to look at, it also gives a link for the current recommendation. And that, for my presentation, that's what I was going off of because that is the current. Okay, that was all that I had to show for today. So I'm going to ask Aline if there have been any questions that have come through in the chat.
Karen. I just sent a reminder in the chat if you have any questions to drop them in there, but as of right this moment, I do not see any.
Okay, great, thank you. Well, that brings us to the end of today's presentation. On behalf of myself, Aline, and the Provider Outreach and Education team, I'd like to thank you for being here today, and I hope that you will join us for future events. You may now disconnect.